This is a video to demonstrate the process of central line insertion from start to finish, produced by a team at the Royal Berkshire Hospital in Reading. This is part of a programme using a mix of e-learning and simulated practice to teach the fundamentals of central line insertion prior to supervised practice on patients. You should ask a colleague to assist you. They will need to have knowledge of the procedure, its risks and the assistance you will require. In terms of equipment, you will need a large cleaned procedure trolley, a central line insertion pack, 2 lots of chlorhexidine skin prep, a central line with the correct number of lumens, sterile gloves in your size, and local anaesthetic. You will also need a central venous pressure transducer ready. For this, you will need a 500 ml bag of 0.9% sodium chloride, the pressure transducer, and a pressure bag. Have a sharp spoon close by. Where possible, you should seek informed consent from your patient by briefly discussing the benefits and risks of the procedure. Explain that they will need to lie still under a sterile drape and that you will use local anaesthetic. The patient will need to be appropriately monitored throughout with pulse oximetry, ECG and blood pressure measurement. At this point, optimise the patient's position to improve the ultrasound view of the vein, increase the chance of success and reduce the risk of complications. For an internal jugular line, the optimum position is with the patient's bed roughly level in a reverse Trendelenburg position or head down. The bed should be at a comfortable vertical height for the person performing the procedure. Briefly check that the site is suitable with ultrasound. For a femoral line, the bed does not need to be level. The leg should be flexed at the hip and knee and externally rotated. Using ultrasound, demonstrate the vein, which should be compressible on pressing down with a probe, non-pulsatile and oval-shaped with thin musculature. You will need to prepare the pressure transducer with a 500 ml bag of saline, pressure bag and transducer pack. Check the fluid is 0.9% sodium chloride and is in date, then insert this into the pressure bag. Open the pack and ensure all the components are tight and close the roller clamp. Spike the fluid and ensure the fluid is securely hung in the pressure bag. Hang the bag, then inflate it to 300 mm of mercury. The green portion of the indicator will be visible. Reopen the roller clamp and use the blue toggle to run the fluid through the set. The transducer is now ready to connect. Once you are ready to begin, start by opening the packs, maintaining sterility. Put on the hat and face mask. With care, open the additional equipment into the field you have created, including the saline syringes. Perform a surgical hand wash. Dry your hands with the sterile paper towels, then don the gown and ask your assistant to tie it at the back. Put on your sterile gloves. Attach the syringe to the needle and ensure you have all the required items ready. Now you need to prepare the central line for insertion. Flush each lumen with the normal saline from the syringes in the pack, bearing in mind that you will need to flush the central line at the end of the procedure. Ask your assistant to help draw up the local anaesthetic. Now ensuring the patient is appropriately positioned to thoroughly clean the insertion area. Begin at the insertion site and clean in a circular motion outwards. Repeat with more chlorhexidine. Cover your patient with a fenestrated drape. Note the orientation on the label and use the adhesive to secure it before carefully opening it further. Prepare the probe cover, then ask your assistant to pass the probe to you. There should be a layer of KY jelly on the probe before it is covered. Maintain sterility as you cover the lead and secure the cover in place with an elastic band included in the pack. Smooth away any air bubbles that might reduce the quality of the image, then add sterile KY jelly. Check the orientation of the probe, then locate the vein with the probe pointing towards the ipsilateral nipple. Ultrasound guidance will help you locate the area whilst ensuring you do not inject local anaesthetic into the vein. Inject subcutaneously in the target area, aspirating before each injection to ensure you have not hit a blood vessel. Allowing time for the anaesthetic to work, prepare your equipment. Ensure the syringe moves freely and prime the guide wire. Place the guide wire in easy reach of the target site with some gauze. At this point, you should have a procedural pause. Check you have the correct patient and consent where possible, indication for the central line, supervision, consideration of contraindications, equipment and an appropriate assistant, ultrasound equipment and good views at the intended site. After rechecking probe orientation, use the ultrasound to guide your needle insertion. Hold the probe in your non-dominant hand. Insert the needle at around a 45-degree angle with the bevel facing up. Carefully follow the tip of the needle on the ultrasound until you access the vein. It should be easy to aspirate blood at this point. Detach the syringe, taking care not to move the needle. Expect to see a slow venous backflow of blood. Insert the guide wire. There should be no resistance. Look out for any changes in the ECG and withdraw the wire slightly if these occur. Leave at least 10 centimeters of guide wire externally. If using the Rollerson syringe, there is no need to disconnect the syringe. Pass the guide wire through the middle of the syringe. Take care to insert the guide wire introducer firmly into the plunger without displacing the needle. If you face difficulty in advancing the guide wire, sometimes adjusting the angle of the needle can resolve this. However, do not force the guide wire if there is resistance, as the needle may have become displaced from the vein. Remove the needle but leave the guide wire in place. You will need to place some gauze over the site. Ensure you hold the guide wire at all times to avoid accidental embolism. Examine with the ultrasound to confirm the location of the guide wire within the vein, using both a short and long axis view. It can be seen as a bright white point on the image. Follow it as far as you are able to. Next, use the scalpel to make an incision in the skin. Run the blunt end of the blade along the guide wire and make a confident incision. Use gauze to control bleeding. Load the dilator onto the guide wire, holding a portion of the wire at all times. Insert the dilator with a twisting motion. There may be a little resistance as it passes through the skin and fascial layers, but it should not be difficult to insert. The dilator only needs to be inserted to the depth of the vein. Remove the dilator holding the wire at all times. Use gauze to control bleeding. Now load the central line onto the guide wire. The wire will usually exit from the most proximal lumen. Holding the wire at all times, insert the line. Now remove the guide wire. To secure the line, use the needle holders to place a suture through both sides of the lumen junction. Cut excess suture down, leaving enough for it to be cut easily when the line is removed. Use a syringe to confirm all the lumens aspirate easily, then flush them all again with saline. Connect the transducer to see the pressure waveform. To get an accurate pressure, zero the transducer. To do this, open the three-way tap to the air and close to the patient. Then press 0 CVP on the monitor. Reopen the tap to the patient and close to the air. If a venous pressure and waveform is seen, the line is safe to use. A chest radiograph should be obtained to confirm position, but the line can be used if placement in a vein has been confirmed with a pressure transducer. This will avoid unnecessary delays in initiating inotropic therapy if required. Remove the sterile drape, then apply a clear dressing over the entry site. Tidy the area, ensuring to carefully dispose of all sharps. Wipe down the trolley and clean the ultrasound machine and probe. After the procedure, you will need to ensure accurate documentation and request a chest X-ray.